So good afternoon, everyone. My name is Jeff Thies, Director of the Institute for Business Ethics and Sustainability, and a clinical assistant professor here at the College of Business Administration. It's really a pleasure to have you here this afternoon, members of our VADM 4950 class, as well as other community members and members of the Sisters of St. Joseph of Orange that are here this afternoon for the presentation as well. Prior to coming to Loyola Marymount, I was a mission integration executive with St. Joseph Health. And a few years ago, I had the opportunity with other executives to go to the place of the founding of the Sisters of St. Joseph of Orange. The sisters in that congregation are one of the founding sponsors of Loyola Marymount University. And it's their CSJ Center that is sponsoring this symposium of which this presentation is a part. Anyway, we went to Le Puy in the south of France, and where the congregation was founded, 1650, if I remember my history right. The sisters are nodding, so far so good. And they were founded really around a couple of visions, and that is that their mission and their charism was to bring people together and to bring people to God, which is one of the reasons why reconciliation is such an important word in the naming of the center. But they also understood that that's really done when they partner with others to really engage the social needs of a community. And so very early on, they would go out into the community and really divide the community and meet with people throughout the community and basically say, what are the needs of the community and how might we respond? And that became a deep part of the mission of the congregation throughout their centuries. I tell that story because it's so profoundly relevant to us here in this College of Business Administration. We've been reflecting pretty deeply, certainly in our class the last couple of weeks, that business doesn't operate in isolation, that business functions at the intersection, really not just of business enterprises, but of society, of public policy, and the profound issue of human need. And good business and creative business will be those organizations that partner to really bring value and address the profound needs of society so that collectively we can pursue what the Chief Executive Officer of Unilever said, talking recently, that simply we should all be committed to nobody being left behind. And that's a business imperative as well as a profound social need. And so it's so great to have the opportunity with Dr. Heather Tarleton, Associate Professor from the Health and Human Services Department of Loyola Marymount, and John Maceri, Chief Executive Officer of the People Concern, to talk about their work and their focus on not just human need, but creative ways fundamentally to manage resources, both social resources and economic resources, from large, complex economic organizations, healthcare systems, et cetera, to more effectively respond to human need. And so that's what we're going to do this afternoon. So first, it's a great honor and pleasure to have both of you here for this panel this afternoon. The second thing is, this isn't going to be a presentation, but a conversation, so thank you for sitting up toward the front. And we're going to start with Dr. Tarleton and then John, and then they're going to share some perspectives, and then we'll have the opportunity for dialogue and Q&A. And I'm guessing if there's questions in between, everybody's good with just go for it. Okay? So thank you so much, and Dr. Tarleton.
Good afternoon, everyone. Hello. So I say to my students, and they sit there as well a little bit. So I'm excited to be here. Although I teach in the biomedical sciences, I'm also a public health scientist. And that has come about because in thinking about community health, thinking about health sciences, it's important to not just focus on individual medicine, but also think about what are the determinants of health in communities. And communities are defined in very different ways, right? A community can be a group of 5 or a group of 500. So when we're thinking about community and the health of communities, we want to actually think about specific determinants of health and behaviors in that community. So the courses that I teach here at LMU focus on bringing students to that perspective of looking at the health of communities and serving within communities, because as a scientist, as a clinician, you are not working for a company, but you're actually working for your patient. You're working for your clients. And in order to work for them and serve them medically, you have to be in partnership with them. You have to be able to truly be a man or woman for and with others, and that's a lot of listening. It's a lot of observing. It's a lot of walking in footsteps, shared experiences. So in my classes, I focus on teaching a lot of the biomedical health science challenges of what it means to be marginalized, what it means to be a vulnerable population member, what it means to be homeless, to live the homeless experience, I like to say, because there's no such thing as homeless people. We're all people, and some of us are currently living a housed experience, and some of us are living a homeless experience. And I like to lead with that, because I think leading with that helps us shift the conversation not towards homeless people as the other, but as towards other individuals or members of our communities who happen to be living a homeless experience. And a lot of the next conversations are about, well, what caused them to be living a homeless experience and I'm not, you know? What are my safety nets that have prevented me from living a homeless experience, and what are the safety nets that they don't have that restrict their ability to access housing, medical care, food, and the myriad of comforts that we all have access to as members of a housed community. Bless you. And then I also try to talk with my students and just talk with pretty much anyone on campus and off campus about solutions. And when we're trying to generate solutions, whether they're healthcare solutions, business solutions, we really have to think about, does it fit an articulated need? There are normative needs in which I think somebody needs this in order to be healthy, but those can be very different from felt needs and expressed needs. And we want to make sure that we are balancing the normative needs with those felt and expressed and articulated needs of community members. That's how we get to more than just, quote unquote, feeding the homeless, right? And we start working in partnership with individuals living the homeless experience to try to, if we can't solve the problem of homelessness in terms of providing housing, what are some other related issues or problems that we might be able to help advocate solutions for, or help those members of the community identify resources or access. So a lot of this is about advocacy. It's about you as a housed person, you as a person who's a member of the LMU community. That itself brings privilege. You can use the bathroom anywhere on this campus without being assaulted or told to get off campus or arrested. That's a privilege that others who are not LMU community members, they don't have that. You can't just come on this campus and use LMU resources. Your ID card gives you access to those resources. So it's important that even if you are someone who views yourself as perhaps a lower socioeconomic status, simply being here in this space, in this environment, confers privilege to you that everyone doesn't have.
Thank you. Good afternoon, everyone. Can you hear me? Is that okay? I'm usually not ever accused of not being loud enough. Well, it's really a privilege to be with you today. So my part of the program is to tell you a little bit about our organization and then to focus on some work we've been doing for the last 10 years on people experiencing homelessness who are also high utilizers of the healthcare system, particularly the hospital emergency room. But before I get into that, I just want to, and I really appreciate, Heather's introductory comments, because the work we do, that the people concerned, we're a nonprofit social service organization that provides housing and wraparound services. So primary health care, mental health care, substance abuse treatment, and domestic violence services for people experiencing homelessness and victims of domestic violence. And we've been doing that for 56 years. The people concerned was actually formed in the merger of two organizations, the Ocean Park Community Center, which has had many volunteers. We've been very fortunate to have many, many LMU student volunteers over decades, and we're very grateful for that. And LAMP Community, which is an organization that was actually founded by a woman who was one of my predecessors at OPCC, who always wanted to work in Skid Row with people with serious mental illness. And so in 1985, she went to Skid Row to found LAMP Community, and the organizations came together 3 years ago. So we have a very rich history of serving people who are extremely poor, extremely vulnerable, and extremely marginalized. And so our typical program participant is someone, I'm talking about, and I'm focusing for today's presentation on the people we serve who are experiencing homelessness, not victims of domestic violence, although many people experiencing homelessness, are, especially women, are also victims of domestic, physical, and sexual assault as well. We tend to work with people who have been on the streets for a long time, many years, sometimes decades. They almost always are struggling with serious untreated mental illness, often substance addiction, always chronic health problems that have been exacerbated by life on the streets. So things that we take for granted: if you have asthma, if you have diabetes, if you have heart condition, you have access to health care, you're still living with those very serious chronic health conditions, but you have access to care and you can manage them. And so they are not as acute as we find them in people who don't have access to health care. And so we find that people who are living on the streets age much faster. Their medical conditions accelerate in a much faster rate. And so that, for us, has been the context of our work for a very long time. And about 10 years ago, and so this kind of has an intersection of social determinants of health, social services, housing, and the business piece of it when we look at the hospital, the healthcare system. We realized that, and this is not new information, but people experiencing homelessness are often very high utilizers of hospital emergency room services, and there's a variety of reasons for that. Generally, they go to the hospital ER not because they have a medical emergency that needs to be treated right in the moment, although sometimes that's the case. But by and large, they're going there for other reasons. Often it's familiar to them, they feel safe, they're treated well. In California, there are very strict protocols about making sure that people are medically stabilized before they're discharged, and actually those requirements have actually increased this year with the recent passage of legislation that requires healthcare centers to be more proactive in their discharge planning. And sometimes they will have chronic health conditions, which they'll experience an episode and will drive them into the hospital emergency room. So the typical scenario is they go to the ER, they're medically stabilized, and then they're discharged back to the street, and in a few days or a few weeks, they're right back in the ER. And this continues over and over again. And the challenge is that most of them are going to the ER because what they really need is housing and wraparound services. So they need access to ongoing primary care, mental health care, substance abuse treatment, that is an alternative outside the healthcare system. And so we decided to start with a very small pilot program with one of our local hospitals, Providence St. John's Health Center, which happens to be a Catholic hospital, very well aligned with our mission of serving the poorest and most vulnerable. But also from a business perspective, these individuals cost the hospital system a lot of money because this recycling in and out of healthcare is a very expensive intervention long term. And if people have to be hospitalized, the inpatient costs are significant. And so what we decided to do is we partnered with our local federally qualified health center, which is our local nonprofit. You may know them as a community clinic, but Venice Family Clinic, the People Concern, and Providence St. John's Health Center to start we started with 10 beds. We set aside 10 beds in one of our interim housing programs as a respite program, so that what we said to the hospital is rather than discharging these patients back to the streets, discharge them to us, and we will take responsibility for making sure that they're housed and connected to primary care and any other wraparound services they need. And we want to look at this over a period of time, and we want to see sort of pre and post intervention, what are the effects? Of course, our hope was that the quality of life for those individuals would increase, that their health would stabilize. Ultimately, what they needed was housing with ongoing support, and that we would see a decrease in the number of times they went to the ER and went to the hospital, and that the cost would drop precipitously. So that was kind of our hypothesis. We started with the assumption that most of these individuals were not coming to the hospital because they needed emergency care, but for the reasons that I described earlier, and we wanted to see what would happen. So we started, the first year we had 190 unduplicated patients that came through the pilot. And it became, the way we did it is we have registered nurses on our staff who are part of our health and wellness program at the agency. We actually took 2 of our nurses and we embedded them in the emergency department because we wanted them to do kind of the assessment of, in real time, what were they seeing as the patients were presenting. And not surprisingly, what we found is about 98% of the people presenting did not have a medical emergency that they needed to go to the ER. They were coming in for the reasons we described. We did have one gentleman who came in with a broken wrist, and that was because he was drunk and he fell down and he broke his wrist. So he was the only person that we encountered in the first 190 patients that really had an acute medical condition. So that was interesting because what it told us is that in fact, the social determinants of health that were driving these patients into the ER was very much present in Santa Monica. We, over that period of time of the 190, we were able to get 113 of them actually to agree to move into either interim housing, and we had out of the 113, about 102 of them were in interim housing, and the other 11 needed a higher level of care. So they were actually able to go. We were able to connect them to board and care, and in a couple of cases, skilled nursing facility, because they actually had a need for a much higher level of care. And so we tracked them over the year, and what we found in the end was that the average cost of the hospital ER visits dropped from about $1,800 to less than $800. And the average inpatient cost dropped from about $34,000 to under $5,000. And the average number of days that people were hospitalized dropped from six visits a year down to 2. So we said to Providence St. John's, we want you to just do a random sample of your data. Just randomly pick 10 patients and see the pre and post intervention, what the cost savings were for those 10 patients. So what they discovered is the 10 patients they selected at random turned out that there was $300,000 in cost savings. And it turned out that of the whole cohort, the 190, there was about $1.5 million saved in the course of just 1 year. That's a lot of money, right? In addition, the quality of life for those individuals improved significantly because what they really needed was housing and ongoing wraparound supports and services. So that was the beginning of work that has now expanded from 1 hospital to 6 private hospitals on the west side. So what's interesting in Los Angeles County is we're in the, you're familiar with the service planning areas, SPAs. It's a health, Department of Health construct that kind of divides the county of Los Angeles. There happen to be 8 of them. And on the west side, where we are, we're in SPA 5. It turns out that we don't have any county hospital facilities in the SPA. We have 6 private hospitals, but no county facilities. So de facto, what ends up happening is people experiencing homelessness go to these private hospitals. That doesn't mean that people experiencing homelessness don't go to private hospitals and other SPAs, but there are county facilities where they would normally be transferred and treated. And so we had this very unique opportunity to look at, well, what if we used our small pilot as an incubator to look at if we embedded patient navigators in all of the 6 hospitals who really were trained and had expertise in dealing with this population, who could make warm handoffs to the local community resources, what change might happen over time. So it was not just about saving money, although that is part of the business case for this, because hospitals are businesses, even nonprofit hospitals are businesses. And with all the changes in healthcare, they're very keenly aware of trying to reduce costs but still provide high quality care. And this is a very challenging population for the emergency department staff. You know, it's not the hospital's fault. They're not in the business of providing housing and wraparound services. You know, you go into emergency department, it's a fast-paced triage model, right? You assess, you stabilize, and then you discharge. That's the way it's set up. It's not because they're trying to be mean. They have other patients that they need to see. That is different than the way we work as an organization, because we're really going the distance with somebody. Because if someone's been on the street a long time, you don't just pick them up, move them into housing, and they live happily ever after. That's not the way it works, especially people who are struggling with multiple barriers and challenges in their lives. And so that work became the springboard for now. Over the last 3 years, we've been working with all the local hospitals and helping them all, and they have all created their own patient navigator. It looks very different in each of the institutions. Sometimes it's someone on staff in the hospital, sometimes it's a contracted person, but they are each developing expertise and working with their patients and helping to build a network. Our next step is to, and we're kind of in the throes of this right now, is to get all of them. They're all linked on a data system to actually share patient information, but we haven't been able to break through some of the legal barriers in terms of real-time data sharing, because our goal is to look at, and I'll stop here with just this last anecdote, because we met last week, but our eventual goal is to get them networked so that as patients are coming into the emergency departments, the other thing with many of these individuals go to multiple hospitals, sometimes in the same day, often within the same week. And so it's important for us to be able to serve these people effectively, to really understand what their patterns of utilization are. So we're working on that, and then trying to create a master utilization database so that we really can look at over time, what have the impacts been. We met just last week and we asked Cedars-Sinai, which I'm sure many of you are familiar with, a very large private hospital, and they pulled 3 of their highest utilizers over the last 6 months. So from July 1st to December 31st, just 3 patients, 3 individuals, 2 men and a woman. One of the men had 71 emergency department visits in 6 months. That's about every week, like 3 times. One had 54, and the other one had 59 visits. So when you think about these are just 3 people, just 3, and they see on average about 150 to 200 unduplicated people in their emergency department every month. Imagine the amount of money that's being spent, and the quality of life for these individuals is not improving because they're recycling in and out of these expensive systems. And I say that not as an indictment of Cedars. Cedars is a wonderful hospital and has done a great job on their navigator, but it lifts up this idea of how complex the needs of these individuals are, and how broken our systems are, that we aren't able to connect people in more meaningful ways to ongoing care. So I'll stop there, and if there are any questions or comments or thoughts.
Yeah, there were a lot of just key points there, and I think it's important to understand, especially for the students, the model of why hospitals are so expensive. And I think it comes down to the different ways in which in our country we do have these public and private hospitals. We also have private practices, so that's your primary care physician, it's part of a medical group. And then we have public clinics. And all of these are set up to serve essentially different populations, and they're funded in different ways. So when we're thinking about public health clinics, you often find a shortage of resources because there's a pot of money that clinic is funded from, and that is often an allocation from tax-based sources, right? So you tend to find more of a restriction in terms of how many staff can be there, the qualifications of the staff. The more education a staff member has, the greater the salary, the more sort of disposable products that are used, again, the greater the cost. So the cost increase is not malicious, but it's often a real reflection of what's needed to purchase supplies and then reimburse the staff that's there. You have your primary care practices, so individuals who have insurance, you have a doctor that you go see regularly, and that's an initial disparity with those who are dependent on public health clinics. Is when you show up at a public health clinic, you see whoever's available, right? You don't have a physician assigned to you that knows you and that kind of works with your case. And oftentimes, clients in public health clinics may go to multiple clinics, so they don't always go to the same public health clinic. So there's a discontinuity in care that presents itself, and individuals are not able to receive. Continuity of care is important. You know, your doctor gets to know you, they get to know your life, your behavioral patterns, family history, and it's very difficult for that same relationship to be perpetuated at a public health clinic, especially when a client is going to multiple clinics. So we've already kind of set up a disconnect in care. That disconnect in care is often translated into referrals for secondary care. So your primary care physician, if you need to see a specialist, if you have an emergent issue with an ankle issue, knee pain, etc., that's caught, it's screened for, you're referred for secondary care with the idea that we want to prevent the problem from getting worse. The flip side of that is that a lot of public health clinics and a lot of emergency rooms, because there isn't a continuity of care for those clients, they sort of show up when the problem is almost too far gone, right? Now we're talking about trying to manage the disease or condition, or trying to deal with something that's pretty aggressive, right? The more aggressive the condition, the more extensive the treatment and the higher the cost. So again, the cost can be matched to whether it's preventative or an aggressive treatment, and we're more likely to see the need for higher cost aggressive treatment when a patient has been unmonitored, and that's usually someone who doesn't have continuity of care. So these are just some of the reasons as to why we start seeing these, hundreds of thousands of dollars being spent on ER visits as opposed to preventative care, which has been proven to be just cheaper because you're dealing with an emergent, less complicated disease state or injury state. A lot of times, I actually had 2 students that worked on a project where they noticed being homeless is very stressful on your musculoskeletal system. It leads to a lot of injuries, right? And sprained ankles, pulled ligaments, etc. Over time, those minor injuries can lead to chronic disabilities, right? So we started to see that individuals who were younger, who were living the homeless experience in their 20s, teens and 20s, would end up with these, minor issues, things that bothered them. But as they get older, they're aging into disability. And so now you go from being a young, vibrant 20-year-old who's living a very hard life, a physically tough life, and as you age, your body ages prematurely, your musculature ages prematurely, and now you're a disabled 30, 40, 50-year-old. It's hard enough being housed and disabled. Imagine being disabled and trying to navigate broken sidewalks, trying to navigate sleeping on concrete. I took my students out to live the homeless experience for 3 days, and they're LMU students, all, priding themselves on how far they can run on a treadmill and how healthy they are, and they came back broken. I mean, just physically exhausted, mentally fatigued, the stress from noise pollution, living in LA, it's a very noisy, tough place to be. And so they were able to personally feel, within just 3 days, the trauma, the physical and psychological trauma of what it is like to live on the streets in Los Angeles. So then multiply that by living for weeks or years in an urban environment and having that constant stress on your body. So again, you go to the ER because it's sort of gotten to a point where now that sprain has turned into a tear, and now you're hobbling, and now you go to the ER not for an ankle wrap, but now we've got to deal with possible surgery for a torn ligament or a knee that's permanently damaged or something that's more medically expensive than let's try to work on conditioning these ligaments and so forth. So my students came up with an option for those who would come to the drop-in clinics around the city to offer classes on yoga and Pilates to try to counteract some of that musculoskeletal tension and damage, because you all carry your book bags around with, some textbooks in it. Imagine trying to carry your whole life's worth of belongings. So you've got stuff on your back, you're dragging stuff around the city, and there's no respite from that. You're literally moving around constantly with all of this weight. So the idea was to use yoga and Pilates as a low-cost preventative option to start trying to relax and condition some of that musculature to prevent injury. So again, these are the ways in which we think innovatively about solutions that from a medical standpoint could help break that arc from minor injury to major disability, and then also things that are cost effective that can be used as an early onset intervention for a large group of people. And it also promotes things like positive psychological well-being, community, and then making it a positive experience, right? You're not going to a doctor's office, but you're participating in something that's medically advantageous, but with a group of people. And you're in a quiet room, which is huge, right? To be in a quiet, peaceful, serene space, focusing on yourself, as opposed to being on a sidewalk where there's cars and people and it's all around you, and you're sort of on the defensive at times. So these are, again, the things we want to think about from a not just a scientific perspective, but a biomedical perspective, and also tying the cost of ERs to the aggressiveness of the conditions in which clients or patients are presenting with. In addition to that, a lot of individuals are, as was mentioned, coming to the ER because it's a point of care, not necessarily the point of the right point of care, but it's the most visible point of care for a lot of people. There are a lot of social service, nonprofit points of access in LA, but sometimes it's hard to find those. Contact numbers might change, addresses might change. Knowing if you're welcome there might not be as visible or apparent, but a hospital is, everybody grows up knowing I can go to a hospital. And there are people there who are doctors and who are supposed to help me. So bringing to the forefront more portals, visible portals of access to care, and then also this concept of triage, this concept of when you come in the door of a hospital, is there a person who can help you navigate whether or not the hospital is the right place for you to be, or whether there are other community centers. I personally like a model of having a community clinic at a hospital, sort of attached to an ER. If anybody watches Grey's Anatomy, that's a model that they use, having a clinic, a public clinic, actually in the emergency room, so that you can have this level of triage to figure out, is it a social service that's needed, or is it urgent medical care, or is there something else? Is there mental health is needed at that point? And then having community services that are consistent, that are established, and where we can start thinking about continuity of care. I believe that continuity of care is essential if we're going to have effective preventative services.
The other thing I would say about hospitals is they're open 24/7.
Mm-hmm.
That's the other difference, is most social service providers are not open 24/7. Residential programs might be, but access points are. And that is another huge reason why people go to hospitals, is absolutely they know they're going to be cared for, but they're actually open.
Mm-hmm.
Just maybe a couple of umbrella concepts just to reinforce what you were saying. And so healthcare is about 19% of gross domestic product in terms of the aggregate cost. We're the most expensive healthcare system internationally, and for those of you who are international students and you look at the healthcare systems in your countries, are in profound ways much more efficient than we have in the United States. We're the most expensive, and we don't get health outcomes that one would expect from spending the amount of resources that we do as a country. And one of the reasons for our cost is that the system itself is profoundly fragmented. And you described some of these examples of fragmentation. John talked about utilization of emergency rooms and giving an example of 79 times. The most extreme example I heard of this was given by a physician working in Camden, New Jersey, who was trying to get visibility, and it really is about the integration of health records, and there's a lot of initiatives around doing that, but you talked about challenges related to that as well. He was doing that in Camden, New Jersey, and they found that there was one patient who had visited the emergency room in the previous year 423 times. So that's more than one time a day. So, so on the one hand, that's incredibly expensive, but it also points to the fact that the delivery, both the design and the delivery of care, is so fragmented, and there is not comprehensive visibility and shared strategies around that this really drives up cost profoundly and dramatically. So then one other piece, just to connect it with business affairs, so you've got the economic engines of the healthcare providers that are huge, and so that's a significant business engine, business issue in and of itself. But the other piece is that, for example, at emergency rooms, hospitals are legally mandated to respond to anybody who walks in the emergency room. So they're not being compensated, so they have to cover that cost, and mostly it's through burden shifting to private insurers. So what happens then is the systems negotiate essentially their price structure with private insurers, and that underwrites a lot of the kind of care that we're talking about here. And so then that becomes a burden to businesses who are needing to figure out how to handle the escalating healthcare costs to provide insurance for their employees. And then sometimes businesses respond that way by not providing health insurance, or sometimes they handle it by fundamentally adopting health insurance products that drive up deductibles, which means people don't go to the doctor as much as they should because they can't handle the deductibles. And so you have this cycle really of inattention to comprehensive care. And then the final thing I'd say is that the aim is fundamentally to help people never have to go to the hospital. We know as people get older, they will utilize hospital services more. We know that there's trauma, somebody breaks their arm, you need those kinds of services, people have babies, these kinds of things. But for the most part, health is really all about trying to care for the whole continuum of care and be in relationship with an individual so that they never have to be at the hospital. And that requires a level of kind of strategic integration, and we don't have that system. It's really profoundly broken. And so on the one hand, we're hearing, and I'll shut up here in a second, but we're hearing innovation about how to more efficiently use resources really to take care of human need and human beings more comprehensively. But you're also hearing a description of some profound inefficiencies that are sucking up incredible resources. And so you're going to see a lot of disruption in the healthcare space really on every dimension of this because there's so much money there, so inefficiently utilized. So I want to just kind of paint that picture for business students because this touches business in lots of ways and will certainly in dramatic ways moving forward in addition to the public health issues and the individual human care dimensions that you're talking about.
I would say there are nonprofits who are trying to come up with some of these innovative solutions. So, for example, the concept of sobering centers is starting to kind of emerge. And so when an individual, so on this campus, if there was an issue with an individual who's intoxicated, then we have EMTs who can be called to provide sort of that first point of care and to triage to see if this person needs to be transported if it's an emergency situation. When you are living out in the streets of Los Angeles and you are found to be intoxicated, it's typically reported to the police. And then the police essentially make the decision to either take someone to jail or to take someone to the ER. Right? The sobering center presents an alternative to both of those models because someone going to jail creates a whole other set of criminal justice issues for an individual who already is dealing with hardships. And then going to the ER again kind of takes a individual who doesn't have necessarily an emergent need to a place where the cost of care is going to be a lot greater and might be mismatched with their current need. So with the sobering center, there are agreements between the sobering center and, for example, LAPD, where the police officers can bring the individual to the sobering center, and the sobering center will provide a more acute level of care. Sobering centers are usually staffed by nurses, nurse practitioners, and then counselors. And these counselors could have a history, a list of experience with mental health issues, with providing social services, and so forth. So the sobering center is a place to deal with the acute issue of intoxication, whether it's alcohol or substance abuse, while then connecting the individual with the social services or mental health attention that's needed as well. And again, it's a lower cost model. The resources there are pretty straightforward. It's pretty much cots, cleaning supplies, food, water, hydration solutions. This cost for the staff, to have that staff with that level of training is pretty low. Usually physicians broadly supervise the sobering center, but it's really nurse practitioners, nurses, LVNs who are providing the care, and it's because the care that's needed is equivalent to what an LVN or nurse is trained to do. So you cut costs by adjusting the staff, and then you also cut costs by focusing more narrowly on the issue of intoxication, as opposed to if someone is sent to the ER, there are a lot of these just blanket ER costs that get thrown in. And those blanket ER costs don't match the current situation for the individual. So I'm a big fan of these sort of small scale, very specific solutions. And if we can kind of have these disseminated more broadly, so instead of one sobering center, have perhaps one or two for each spa, working more closely with local law enforcement to make sure they know about all the options for sobering centers. Then we're working in partnership with the larger medical system to really more accurately triage individuals. But that's because LMU students have a safety net. You have your EMT service that's on campus, but individuals who are living in the streets of LA, they don't have these safety nets. So they often get dumped in the criminal justice system, which creates inequities in terms of police records and arrest records, which further limits someone's likelihood that they're going to have a job or housing, or they get dumped into the ER, which drives up a lot of these costs. So the sobering center can deal with the acute and then also start getting at that issue of the intoxication. Why are you intoxicated? Why are you under the influence of substance? Is there something we can do to help you deal with the reason for the intoxication, the underlying reason for the intoxication?
So two more examples of that. One, psychiatric urgent care centers are very similar, focusing on people who are experiencing an acute episode, struggling with mental illness, as an alternative for being institutionalized or hospitalized, and also as a diversion out of the emergency room. So these are set up to be 23-hour hold centers where mostly law enforcement can actually take people as an alternative to taking them to jail, or if they're not going to stay in the emergency room for a long period of time. So that's one option. In terms of the quality of life, something that we've been involved in for many years is homeless court, and it is a diversion program essentially for mostly people who have had quality of life offenses, tickets for loitering, public intoxication, not felony crimes at all. So these are mostly low-level misdemeanors. And they can go through a process where they can actually, if they participate in the program, can have those warrants, tickets cleared. And so once that's done, their ability to work, their ability to access housing, goes up exponentially because they don't have all this baggage that often is really minimal, compared to keeping people from working or keeping them out of housing because you got ticketed for sleeping in a public space, for instance. The other thing, too, is we focused a lot on the cost in the healthcare system. I think we also forget that there is a tremendous cost in the first responder system. So part of that is healthcare, and that police and paramedics, I think there is this idea that if you leave people on the streets, it doesn't really cost us anything because they're just kind of out there doing their thing. But in fact, it costs us a tremendous amount because at one point or another, most of those individuals are going to interact with first responders, either law enforcement and or paramedics, or often both. And so that is a huge driver. And I know in Santa Monica, the fire department spends less than 1% of its time and resources on actually fighting fires, and about 25% of its calls are related to people experiencing homelessness. So there's a disproportionate use of what are supposed to be public safety resources being used to address issues connected to people experiencing homelessness, which kind of goes back to the social, it's this sort of vicious cycle. And when we look at resource allocation, that we're heavily weighted in expensive, overutilization of expensive interventions, that money could be recycled into providing housing and wraparound services that are far less expensive and would have far better outcomes, not just for the individuals experiencing homelessness, but for the general community as well. The quality of life improves for everyone.
Shall we ask if there's questions?
Sure.
Or any questions, or I'll try. Yeah.
Why do you think it is that if it saves so much money to have preventative care, and like you said, I think through $1.5 million were saved, why isn't the system currently doing more to have these preventative measures if it saves so much money in the long run?
If there's so much savings in these preventative strategies, why hasn't the system adopted these strategies more extensively?
It's a great question. You want to take over first, and then I'll.
There's a lot of, given that our system evolved, our medical system has evolved in such a fragmented way, trying to connect all of those pieces is really like trying to get 100 different people to the table to agree on doing things the exact same way. And that's just, the short answer is red tape and bureaucracy. And agreeing on a plan, agreeing on one plan to do everything. A lot of, in other countries, they began from zero to a socialist or social or sort of community-based medical care system. So they never had to deal with negotiations and adoptions and trying to get cooperation across different sectors. It just began that way. So it's sort of like teaching an old dog new tricks. And it's very tough. And I think you need a champion or an advocate for it. And you can think of doing it at the federal level from the top down, which is going to be politically contentious. And that's like the Affordable Care Act tried to bring some harmony to it. Not perfect, but the Affordable Care Act was an attempt to try to smooth out and connect these pieces. And it has pros and cons to it. But it's such a politically divisive piece of legislation that the conversation is less about how do we improve the current system and more about my idea is better than your idea. And so I think you have to take it out of a political spectrum and put it into an administrative context, and maybe starting at a smaller scale, getting a smaller scale adoption or local adoption of a solution, and then have that adopted more widely. So perhaps a state, every state handles their share of programs like Medicaid. So perhaps the way in which California handles its implementation might serve as a model for other states to adopt. But again, you've got a lot of different opinions about the best way, and there's a lot of cooks in the kitchen, essentially.
Yeah, I would agree with that completely, and I can just share with you sort of our experience working with the 6 local hospitals. So it's very interesting when you have conversations with the individual decision makers or the leadership of individual hospitals, and this is true for every hospital, so it's not unique to one institution. They are very much interested when they look at their own data, and this was one of the primary drivers, is when we asked Providence St. John's, don't take our word for it, use your own data, use your own patient data, do random polls, because we really want you to be convinced that this is going to work for you. When you have that conversation, it's much easier to convince them that it's the right thing to do because they can see. It's very clear. They trust their own information, and they're willing then to invest, in more preventative, kind of upstream solutions. When you have the same conversation across systems, then you start getting into territories and competition and people's turfs, and it's very interesting. It's a little, I have to say, it's a little odd because it's basically the same information. I mean, each institution is looking at its own information, but the information is very similar. I mean, the question has been asked and answered that it saves money. There's no question that these interventions save money and significant amounts of it, but getting them to work as a cohesive unit around it, this systems change, is very difficult. So I share that frustration because as I talk about this, and I do it often, it's like a no-brainer. You'd think that, well, why wouldn't everybody want to be doing this? But it is interesting, the barriers and the challenges, and we tend to work with the ED staff, the discharge planners, the social workers, and the community benefits people. But when the legal departments get involved, they'll, no offense to any lawyers in the room or future lawyers in the room, but it's like they're trained to say no. They're almost, their job is to tell you why everything won't work, rather than saying, well, let's start from a place of how can we make it work so that it's legal and ethical and everybody's protected. So that's also been an interesting, revelation, that you think that folks, especially at this time in our history, would be much more interested, especially with the volatility and all the changes in healthcare, would be much more interested in focusing more on preventative interventions because we know that they work. But systems change is really, really difficult.
So your question scratches at the real struggle of the dysfunction and fragmentation of the American healthcare system. So it's hard to answer without getting into a lot of those kinds of pieces inevitably. Just to highlight a couple of things, historically, hospital systems were paid in a fee-for-service model, which was any time any service was provided, then that was billed for. So that became, one kind of extreme example of that is if you go in for surgery, that's an invoice. If you get a hospital-acquired affection and they treat that, then they would invoice for that. And then there was pushback to that saying, well, wait a minute, you guys caused the infection. We shouldn't be paying for that. You should be paying for that. Or wait a minute, if you hospitalize someone and you provide services so that you discharge them healthy, well, then they shouldn't be coming back in a hospital within the next 30 days. So we're going to change our reimbursement rates based on readmission criteria. So you have a lot of movement really around this fee-for-service piece, but that has historically been kind of the economic engine underneath a lot of this. Mm-hmm. That's moved to more of a value-based these are the phrases that are used, population health management, where you identify a distinct population and you basically help them both acquire and maintain health, and you ideally are paid based on those outcomes, not on a fee-for-service model. But that requires integrated databases, integrated systems, and we don't have all of those things. And even 10 years ago, we didn't even have the technology infrastructure to even get the data that could be shared, much less having an infrastructure to share the data with all of the legal concerns about that and the cultural concerns that John rightfully identified. So it's a big set of issues, and in the one hand, the population that we're talking about in some respects demonstrate the brokenness of it mm-hmm. and the opportunity in it really most profoundly. Mm-hmm. And so there's a lot of pieces to the question.
And to throw another layer on top of that, it's insurance companies.
Mm-hmm.
So each so you have individual hospitals and systems who have their own preferences in how they do things. And then you have insurance companies, which are sort of negotiating shared costs between the client and the medical provider. And then you have insurance companies who all do things a different way. So Anthem Blue Cross has recently, in the past few years, decided that if you have an HMO, preventative care, your annual physical, which is preventative care, is of no cost to the client, right? So that specific insurer has decided to go ahead and try to promote the usage of annual physicals for screening by decreasing the shared cost to the client. So it's zero cost. If you're going because you're sick, you pay a copay, but if you're going for a preventative care appointment, then there's no copay. But again, that one insurer has decided to absorb the cost or redistribute it somewhere else to promote preventative care. So again, we have so many layers, and a lot of this comes down to talking about, I have my students, although they're health science majors, talking about capitalist systems versus socialist systems, and we think of them politically, but they really are about choice, consumer choice, and with capitalism, you have more choice, but there's also more heterogeneity and diversity in regulations, in standards, and in business models. In a socialist system, you get this uniform across the board service provision. You get more uniformity in rates, so things are standardized. There's no, person A pays the same as person B for, the same service, but you have to be willing to accept that with that standardized cost, there's a loss of freedom or input, right? So things are just decided from the top down, and they just are that way. And that's feasible in socialist systems because from day one, people have decided that this is not a community discourse issue. This is a healthcare for all issue, and we're willing to accept that assumption. We're willing to pay higher taxes because it does cost more money to have that system, but that's a cultural value. And it's harder to transplant cultural values when we as a country have started more from a capitalist base and not again trying to suppress anyone, but that's just simply small businesses started up and started to aggregate and make bigger businesses, and that's just sort of the emergence of our medical system. You have fee for service. Insurance came later on top of that. Medicare and Medicaid kind of jumped in the mid-1900s, like around 1950. So things just kind of started to be piled on. And so it's complicated. And because we started off in this piling on method, it's going to take change, again, at those smaller local levels to kind of streamline and consolidate. And I think that's where you have individual hospitals looking at their data, making decisions, being willing to open a clinic or partner with a clinic or change, and then hopefully that uniformity or that streamlining will be adopted by the neighboring healthcare system. And then now you've got two healthcare systems doing awesome things because every business loves good press. And so now the other one wants to jump on board. So I think it has to be that grassroots expansion along with positive results, good press, and now everyone is, at least leaning towards pausing and thinking about how can we do better? How can we take advantage of this cost savings? Because we see other people have tried it and it works. So.
Go ahead, please.
So I have a question.
Sure.
You touched on technology and trying to numerous hospitals. Well, Cedar Sinai has nuclear that's going on all the time. Is there going to be communication with them about trying to get them involved in something like this, or are there any pipelines or anything?
So there have been some initial conversations with them because we realize that unless we break through this data sharing piece, we're not going to be very effective long term because it's going to be critical, as I said earlier, in real time to understand what's happening with these patients. So I think the breakthrough is going to come if we can get over the hurdle of the fear of litigation and exposure and liability, which is real in every business, and that's not unique to healthcare. But the fact is, it's being done. There are lots of models. There are healthcare systems in Northern California that have developed, data sharing agreements. There's plenty of examples. We just can't seem to get our local folks to understand that they're not the first ones to do this. And then I think with the use of really interesting technology that already is available to us, just how do we harness that in a way that's not unique to one system or one institution, but can be shared across institutions, and get the other institutions open to the idea that it's really okay, to do this. And it's going to take a minute to get people there. But I've been at this for 3 years with them, so some days it feels like all of my life, and then sometimes I have to realize that these steps are made, progress is made incrementally.
The infrastructure for that kind of data sharing is established. That's not really what the problem is, as you were saying. It's the cultural and legal issues. If you think about it, so you go to your doctor and you get a diagnosis, and that's private, and the doctor legally can't share that with anybody, and of course you don't want the doctor to share that with anybody because that's private. And then you go home and log into WebMD, and you give the same diagnosis to a third-party company because you want information. And oh, by the way, sometimes may be better served if you have kind of an open source approach so that you can get into a community of people with the same diagnosis. So there's this dynamic of public that benefit really in making information more readily available, but we've got a legal privacy structure around health data that's quite different from that. And your cultural issues are exactly the case. And I was in Catholic healthcare, and the competitiveness within Catholic healthcare and between hospitals within the same system. And so there's many dimensions to this, but the pieces are getting there and have been there in the last few years. It's really just the disruption, which is both local in the ways that you're saying. But Walmart is going to be one of the largest primary care providers, and Amazon is working with Buffett and Morgan Stanley. There's going to be large disruptors to this space as well, so there's going to be a lot of moving parts.
Well, and I think it's also interesting, and I see this at a kind of a micro level now, that to your point, you have hospitals or institutions working together that are both collaborators and competitors at the same time. So having to navigate that can be tricky sometimes, right? Because there's always a sense of proprietary information, or wanting to make sure that your outward-facing, public persona is one of being a good community partner and playing nicely with others. And yet, there are very real business interests that are at stake. And so it's interesting balancing, both of those competing interests.
We have about 5 minutes left. Are there any other questions?
I was going to just make a comment that I think this is also where, again, capitalism gets a bad rap. But here, when you think about what somebody like, or a company like Amazon could do with so much leverage and power and social capital, right? If it sets its mind to do that, to make that shift, it can be the innovator and the influencer, because that is both demonstration on a large scale and a lot of positive press. So I think that there are lots of models without trying to copy a socialist model on a system that it just makes zero sense, and that it's very difficult because you almost have to break everything back down to zero and start over. There are ways in which we can take advantage of certain business models and economic principles to rely on Amazon or Walmart or whoever else wants to emerge as an innovator or an advocate or a leader in this, to make advances, right? And with that comes the technology, with that comes the buy-in. And so there's ways to do it. And the technology is improving across some systems. There's some systems that are still trying to move from paper-based records to adopting electronic medical records. It's still a relatively new concept for some systems. And with that adoption, you now have to make sure everyone's using electronic systems that can talk to each other, right? Because some people adopt one system and then others adopt another system, and now they don't talk to each other. Now we still have a tech problem. So I think that, again, it's how can we maybe not break everything down and start over, but how can we try to streamline or do something that makes sense?
That's right. So thank you very much for this really important and engaging conversation. Really appreciate that. And really what's being shared on the one hand is passion for and innovation about responding to human need, really for those in many respects who need it the most. And so really want to honor the passion of that work and the sensitivity of the human care that's at the basis of that. Secondly, we're talking about the intersection of private business and public policy and social impact, and that network of how each of those elements intersect with one another and really fundamentally need to work collaboratively with one another precisely so that you get more bang for your buck. I mean, is what we're talking about in some profound ways. We can't afford waste. And so that's another big piece of that. And, you know, in our course, most of you are in business and social responsibility in a global economy. That's fundamentally what the question is. How do we use resources collaboratively most beneficially? And business needs to be a significant partner in that. But it is really at that intersection of social responsibility and social impact. And so we were able to take kind of a deep dive on a very poignant and granular example. That's our neighborhood and our community. So thank you so very much for sharing.
Pleasure.
And thank you.